16,000 overnight, so they are at 56,000, which is huge. The United States, of course, is climbing, and we're at 75,000 cases in the United States now. I want to just talk a little bit again about that when we get into the details. So now there are 175 countries that are affected. So again, that keeps going up, and 23,000 deaths globally. So I want to talk about the numbers in the US. 75,000 cases now. If we look at estimates based on the mortality of this virus, we're really looking, again, if we had no more cases, at the very minimum, we're looking at about 3,000 deaths. We just crossed over 1,000 deaths in the United States now, so that's a big number. But of course, what you know is that this infection is long, and that patients who are ill and require hospitalization tend to have long hospitalizations. And so again, we're early in this peak in New York, and the numbers are going, in US, the numbers are going to grow. So New York is in terrible shape, as I said yesterday, and it just gets worse. So they're at 37,000 cases. So again, well over half the cases that are in the United States. And again, they're early. The estimated peak is still really 2 weeks away. In New York City itself, there are 22,000 cases out of that 37. They have 1,000 patients in the ICU, which you may remember, typically what we're seeing right now globally and in the US is about a 20% hospitalization rate and about an 11% rate of ICU care. In New York City, they have 1,000 out of 22,000, so it's on the low side. And what I don't know is it because they're so short of hospital ICU beds that they actually have sicker patients still in regular beds, or what's really going on, or whether, again, it's just early in the infection and the number of patients that need the ICU beds will continue to increase. So Ohio just did their typical 2 o'clock update, and I really have to just say that I think they are doing a great job, Governor DeWine and his team. We are up to 867 cases in Ohio. 223 of those patients are hospitalized. 11% are in the ICU. What's important to note is there are patients in the ICU who are younger. So the age range in the ICU right now is age 23 to 92, and the deaths are up to 15 in the state of Ohio. Testing's increased. Again, we're still behind on testing, so we expect that the number of cases that we have here is still, we're really underestimating it. What's interesting is 17% of the healthcare workers that have been tested are positive, and that's really high compared to about 5% of other people being tested. I think the statistics really make it clear that the stay-at-home policy that was introduced early in our state compared to New York, they had more cases and they were further along, is really helping. I know that President Trump now just announced that he's going to come out with new kind of policies for COVID. He's really anxious to get everything back to work, everybody back to work by April 12th. Of course, in a perfect world, I think that would be ideal. But I actually think that that's likely to be very much too soon in kind of where we're going to peak. And I think my husband will talk about that a little bit. What I believe President Trump is going to do is kind of pick high, low, medium risk areas to try to get them back to work. But if you think about what's happened in China, then Italy, Spain, and in New York City right now, you can see that it takes a certain number of cases, and when you have exponential growth, then you quickly go up. And what we continue to need to do is to blunt that rapid rise so that we don't overwhelm the healthcare system. And we really, I don't think in the state of Ohio or across the country, we really know that we've even slowed this down yet based on what the numbers look like. So we'll see what happens by April 12th. I don't know what Governor DeWine, of course, will end up doing, but we'll just have to see. So would you like to give us an update on Cincinnati?
Sure, and I'll just add on to your comment about thought processes of where we are in this in totality. In the United States, if you look at the graph of our cumulative cases going up, every day the steps in the graph keep getting larger, which means not only is the total number of cases rising, the rate of rise is still continuing to increase, which means we have to pull out all the stops, and the concept of diminishing our social distancing and our stay-at-home processes anytime in the near future Personal opinion, I don't see it. Lisa's exactly right.
I'm always right.
There you go. I was waiting. Softball. But as I use the same analogy over and over. I probably did the other time we did this. There's a volume of water that's going to come over the levee. If it all comes at once, the destruction is massive. If you can slow it down, you can mop some of it up. And that's why we have to stay apart and really try to slow the rate of this thing. And interestingly, it really does appear that if you can slow the rate by social distancing will actually decrease the total numbers in the end. And that's a worthy cause. You know, in Cincinnati, we're still doing all the things we can think of, right? So the main hospital where I work, UCMC, it has a huge number of open beds, right? We're doing about half of the normal total medical care that we're giving there because everything elective has shut down. We are seeing a fair number of patients who are either positive or being tested for positivity. And because the current testing takes a couple of days, it does slow things down. We do predict that we'll have in-house testing next week with about a one-day turnaround, and there are tests that are faster than that. But as you would imagine, the manufacturers of those tests are sending them preferentially to the higher volume places, the New Yorks, the Washington State, things like that. And we understand, and we are anxious to get them, and we will have those up and running as well, because once you can test and have a 4-hour turnaround, you can then really help decide who needs to be where. It really still comes down to, for people not in healthcare, stay home, stay apart, stay smart. For those of us who are in healthcare, as Lisa said, we are disproportionately at risk. If you look at the normal population and you look at the percent of people who are positive that happen to be healthcare workers, it's way out of proportion, and it's not really a surprise. Despite all of our best efforts, there are still going to be exposures, largely from asymptomatic people. That's the hardest ones because you never know. So I've also been terribly heartened. I can't tell you the number of people who have called and said, hey, I think I have access to some N95 masks. Who knew the number of people who did construction work and drywalling and all these different industrial cleaning people, they use N95s. They're not all the same, and we have to do some fit testing and things like that. But that's what we're running out of fastest, to the point that we're reusing them now. Put it on, wear it for the shift, don't touch it, and then take it out, put it in a paper bag, wash your hands before and after touching, and save it. And it's certainly not ideal. But if we're not doing aerosolized procedures like intubations or surgery, our surgeons do surgery on the upper aerodigestive tract, you can probably reuse them, not in those rarer settings. So that's the kind of stuff we're doing. You've seen out of New York, they're just proposing and practicing the split ventilator model. Vents aren't all that difficult to understand. And in two similar patients of similar need, you can run two if you just split the circuits. We're exploring maybe going up to, if in crisis, up to ventilating 4 patients with a single ventilator. All it's doing is pushing air and keeping it at a higher pressure than you would normally breathe in on your own. The illness is long. We do know that patients who enter the hospital, first of all, they get sicker over a number of days, then they get really sick, and then they stay sick. Those who end up in the ICU are staying many, many days, unusually long. A lot of the things we do where patients come into ICUs, we can turn them around in a couple of days and they can leave the ICU. This is a long process. It's a longer recovery. We're also learning that patients who, once they get sick, from point of symptomatic, they can still shed virus probably every bit of 2 weeks out. So we're probably gonna have to expand even more aggressively the duration of quarantine from initiation of symptoms. And by the way, you were probably shedding virus for 2 to 5 days before you actually felt bad. So it's a long, drawn out illness. That's why, or one of the many reasons, it is so effective as a contagion that it causes so much trouble.
Can you talk a little bit about your ICU volume right now and how many ICU beds you currently have available?
Sure. We have, I've been watching it daily. There's 35 or 40 open ICU beds right now. The ICU teams are stretched because, they're in there doing so much care for the ones who are there. But we don't have a ton of proven COVID positive patients right this minute. There are some in the ICUs, but there's more capacity because our systems have been smart. Places that get in trouble didn't get their places empty before the surge came. I mean, our leadership across our entire health system and in coordination with the entire regional healthcare system is coordinating for how are we going to handle it. When our hospital gets full, our partner hospitals are going to be in a position to help us and vice versa, because it won't come to all at one place at the same time, right? It's going to spread out, and we're going to need to work together to handle this. We're doing interesting things like right now, before we are literally having split the two sides. One side for respiratory clients, one side for not. Completely divided, segregated teams, different approach, triage, order, and prioritize. Lots and lots and lots of preparation. We have a ton of testing capability in those tents we put up last week. Once we get more testing kits, it's not really the right word for it, but it's colloquially correct. We'll be able to do more of that type of thing. So most of what we're doing right now is caring for a very manageable number of patients, but very intentionally and very aggressively preparing for what we expect to come.
All right, thank you. All right, I have some questions that came in yesterday, but let me see if there's any here. Do some people just carry it and not have symptoms?
For sure.
For sure.
Especially young people. Yeah, asymptomatic is a significant proportion. 80% of people don't get all that sick. And there's plenty of them who would test positive and would say, gosh, didn't even know it. And that's part of why we just have to keep everybody apart, because you just don't know.
So one of the things that is coming, and I think will roll out to the population soon, what does that mean? Months, is serum antibody testing. Because again, as we expect that there may be a second wave of this in the fall, again, all bets are off, we don't really know, but within a year, we think probably 60% of the population will be infected. It actually will be helpful to know, right? When there's another outbreak, if you've already had the infection and you already have antibodies, you're someone who, again, is not at risk of getting it again, and can safely come in contact with patients who are sick. So knowing that for future outbreaks will help us, need less PPE and have a better strategy for managing who's sick with it. But again, many asymptomatic, completely asymptomatic infections. But I will point out, as I said yesterday, that this is a disease of younger people as well, right? So the age in Ohio, we do have someone who's 23 in the ICU. If you've been following anything from New York right now, there is a sister couple, sisters who are in their 30s. The one sister is a healthcare worker who believes she infected her sister who's 30, who's really very serious, critically ill, and may not make it at this point. And again, so the death rate is lower. The statistics that are quoted is 1 in 250 is the mortality rate, which is about 0.4% in individuals between 40 and 50. But that's certainly much higher than influenza. And I think we will see through this epidemic that there are young, healthy people that have died from this.
We have talked a little bit before about herd immunity. And part of the big problem with this thing is that none of us have seen it before.
We have no idea why we keep dropping off. So we got a long
thing there. And after that commercial break.
So for those of you that are still here, and unfortunately, I think that all of your questions are disappeared.
Let's go back to
okay, so
immunity.
If you have questions, can you please type them again if you're still on here? I'm so sorry. We have no idea what's happening. Okay, so go ahead with herd immunity.
Right. So, and actually we see people jumping on. So let's give it just 10 seconds and pause for a commercial break for...
Well, no, because then I'm afraid that the video will go off again.
Herd immunity is a concept by where a number of individuals in a community have been exposed to a given disease process. When that is the case, and you have enough such individuals, they cannot act as vectors for that disease process. So if I've been exposed to something and someone over here exposes me to it, I can't deliver it to Lisa because I'm not going to transmit it. I'm immune, if you will, just like I'm going to be to a flu that I've had before. So with COVID-19 or SARS-CoV-2, this novel virus, the situation is that none of us have immunity to it. None of us have the antibodies to stave it off. So we are all at risk, both for our own infection and to act as a vector of transmission to others. So that's why the hope is if enough people get this and are asymptomatic, even if, if we flatten the curve, people say, well, won't it all come back? Not necessarily, because what's going on during this flattening is many people are being exposed. Most of them aren't going to get super sick. And if there's a resurgence, it should necessarily have less penetrance because fewer of us will be vectors for transmission.
Right. So I was saying before it cut off the last time as well, which is this is a reason that I really am a stickler in my practice for everybody getting the flu vaccine. So influenza, we have many deaths across the US each year. The mortality rate is lower than with COVID. But the issue is this, which is even if you're reluctant to get your flu vaccine for yourself because you think you're young and healthy and don't need it, in the same way that we're doing social distancing right now, again, to prevent the spread of the virus, but particularly to prevent it from exposing those who are most vulnerable and the elderly and the most likely to die of COVID. In the same way, getting your flu vaccine gives you antibodies and herd immunity, and it decreases the spread in the local population. So you're protecting others at the same time you get your flu vaccine. So get your flu vaccine every year. Okay, so there's questions that I hope I can see. What is the likelihood of catching this virus should someone need to visit the ER department for something not related to COVID? Would you let that person return to work? Should they work on a business deemed essential and were released by a doctor to return to work? You want to comment about that?
Oh, it's a marvelous question. So like I said, what we're doing, if you came in with an ankle injury that truly needed to be addressed, and we would understand that you'd have to come to the ED, you would go to an entirely segregated area in our case. And most people in most places are trying to keep the two groups of patients truly disparate and truly apart. Is it a higher risk there than, for example, going to a large grocery store? Probably a little. Again, wash your hands multiple times, keep social distancing. And again, we should all be staying apart. If you are working in an essential business, you have to do so. And at that point, the minute you get any symptoms, you're out.
Right. I will say the same thing in my practice right now, which is we have one dedicated room for anyone that has flu-like symptoms, and we're not letting any other patients right now in that room. We're being very careful. And then our other rooms are for people who need to come in to see us for non-flu, non-COVID related issues. And again, it's not perfect. There's another question here about how long the virus lives on surfaces. But the other thing that healthcare workers are now doing is healthcare workers are wearing masks. And the reason we're wearing masks in my office, everyone, again, is not because the masks are protecting us. Regular surgical masks are protecting you in case we're in the asymptomatic carrier stage. And the same thing in the emergency room. So with this stratification of patients and with healthcare workers taking precautions as best we can to clean the surfaces and to wear a mask to prevent spread, I think your risk is low going to the emergency room, but it's not zero. Just like truthfully, it isn't zero going to Kroger's at this point. Okay, we all know wash, wash, wash. How long does the virus live on surfaces? We are all probably doing drive-through pickup. Do we need to be concerned about the virus on packing and clothing? So this question's come up multiple times in the last several days. We know that the virus does live on hard surfaces for several days at least. We do know that it also does live on cardboard and paper, although not nearly as long. I think everybody does have the concern that we're picking up drive-through food. And again, an asymptomatic person who's packing that food could put it on the package containers. So, I think there is a legitimate concern there, but it goes back to, we are all at risk in some way and we have to do what we can. So again, after handling the cartons, after serving your food into your plate, it's hand washing. The good news is on plastics and cardboard, it doesn't live nearly as long as hard surfaces. And in my practice and in the ER, we're all being very fastidious now about cleaning every hard surface after every patient.
frequent hand washing cannot be overestimated.
Of the people who aren't making it, is there anything we know of what makes those specific cases more severe, pre-existing conditions, et cetera? Yes.
Yeah.
So, go ahead.
Well, it's all the things you're hearing about. Clearly, it's age-related. Undeniably, the older age groups, it starts at about 49 and goes up as you go up in decades, and really starts hitting hard over 80. We know that pre-existing conditions, especially cardiorespiratory symptoms, and people say, well, it's a lung thing. Why would the heart be involved? And the answer is quite clear. The heart and the lungs, they're absolutely completely linked and synergistic, right? One gets the oxygen into the blood, the other has to move it around. If either one of them has a problem, when that oxygen delivery issue comes into play, the strain can be on either one. And so cardiorespiratory diseases, be it heart disease, be it lung disease, those are both bad things, undeniably. For some reason, it's hitting men harder. Don't know. But those are probably the main things that we know right now.
Right. It looks to be that there's a very significant inflammatory response in some people. So it's this development in the ICU of something called ARDS, which is adult respiratory distress syndrome. And it's a very severe, very rapid ARDS that develops, which is hence the need for ventilators in so many of these patients. And it's not well understood, although I know that there's a lot of research and clinical trials being done on these patients now to kind of understand the inflammatory marker differences and potentially genetic differences, and why some people, even younger people, succumb to this and die and have very bad outcomes. But it's not clear yet. I mean, I think with this pandemic and the number of cases we have, there will be a lot of information that will come out of this. And again, with the majority of us having been exposed in the next year, there will be herd immunity. So the next time this comes through, it won't be so bad, and we will understand it better and hopefully have treatments available by then. Is the concept of the COVID cloud lingering for up to 2 hours in the air a reality? For example, walking through an aisle at Kroger's after someone has been in the area with COVID and I breathe it in. So if you really want to talk about coughing and droplets.
No, it's just not true. This is a droplet carried virus. Those are droplets that come from a respiratory system. They are 99.9% gone just by gravity within 6 feet of you, and they do not linger. There are disease processes, measles is the classic, where you can have prolonged air spread, aerosolized bits. Not the case here.
My question would be around treatments and specifically about the proposed use of hydrochloroquine and azithromycin. Would you have any experience to share as a nurse and someone in the medical affairs? Right. So I actually just did an interview for Channel 12 about this. I've got some videos and some posts on social media about this. So here's the reality. The study in France that led to all of this discussion about using chloroquine, hydrochloroquine, and azithromycin comes from a very small study in France, 30 patients. There is really interest in this, and again, these are medications that are FDA approved for other indications, for malaria, for autoimmune diseases. There are patients that need to take Plaquenil for other reasons. Again, not large randomized controlled trials, and actually there's concern really about Plaquenil and the combination with azithromycin and causing what's called QT prolongation and EKG changes that could lead to sudden cardiac death. So again, at this moment, we don't have clear data of effectiveness. We have potential concerns about combination therapy. And again, it would be great if this was quickly we could prove that this was a therapy that was effective. What's happening in New York right now is that the very most seriously ill intubated patients who are close to death, on a compassionate use basis, they are being given, this is when patients are that sick, we really do kind of throw the kitchen sink at them to try to save them. And that's a really appropriate time, I think, to be using these medications in patients who are sick and who are not doing well as a trial, even though we don't have great data about it. The problem for me has come, and I really say this very clearly, which is within an hour of President Trump kind of promoting these as the future and as a solution to treat COVID, I got 4 calls from healthy patients wanting to have those drugs prescribed so that they could keep them at home just in case. What that's already done quickly within the last couple of days is my patients who have rheumatoid arthritis and lupus have been unable to get their Plaquenil, or it's been in very limited supply. I understand that now there are places where it even looks like Zithromax is going to be in short supply. So we were not prepared for a mass onslaught in terms of the need for people reaching out for Plaquenil. And what I said on kind of the interview with Sheila Gray this morning is that, as a physician, right, and if you're my patient, I really do want to take care of you and I want to do the right thing. And of course, I want to be helpful and you are my priority to take care of. But during this crisis, I really believe we as physicians have a much larger mission and we need to be involved in this public health policy and taking care of our population. And so I actually really believe that it's wrong for me to prescribe Plaquenil and azithromycin specifically for patients who are healthy and well to stockpile them at home. And it is frankly forced me to have some difficult conversations with patients. And I understand that, but the CDC, has a statement that there is no approved treatment currently available and that there's no data to support it and not enough data yet. And so that's just not what I'm doing and what I believe is the right thing to do.
Well, and I said this, I did a radio show the other day talking about this, and I made the comment, and I'd like people to hear it. If a medication has an effect, it almost certainly has a side effect. And so, mechanistically, chloroquine, for example, doesn't have any, I don't think there's any good reason to think it would be a preventative or an early therapy. And we're talking about something that modulates the immune system to basically try to turn it off or turn it down. So maybe if you're getting this storm of inappropriate reaction in the sickest of the sick, maybe. But having done drug therapy research for decades, and myself in stroke, looking at drug A versus drug B or combinations and like that, it takes years and dozens of patients. And it's being dramatically accelerated as it should be. We're going to have some answers in this stuff very, very quickly. But I wouldn't be betting on this because you don't take a 30-patient cluster, all of whom are sick, all of whom got the drug, and say, hey, Mikey likes it, and decide that that's what we should be doing for tens or thousands of people, especially who aren't sick. That's medical insanity.
Dr. Larkin, as I'm working with elderly patients in both residential and long-term care settings, not much airtime seems to be directed to how we can best protect ourselves during this pandemic. Yes, we're providing... See more where?
Just go to the left there. Right there.
Oh, sorry. Okay.
Yeah, that's good.
That's good. Yes, we're provided gloves, but no other PPE. In less than 48 hours, I noticed on my unit alone, the facility is being segregated with aggressive social distancing, 100% increase in respiratory issues. Despite my personal diligence to minimize my risk of passively infecting the people I care for, I know it's only a matter of time before they're infected with COVID or some other virus. Please remind your viewers that we're part of the healthcare worker spectrum in need of PPE testing and address the legality of forced facility lockdown in the event of a COVID-19 case. So those are all really important and valid, concerns. And, as everyone probably knows, PPE is in short supply nationally right now. And again, everything's ramping up, but New York has been in a crisis, and Art actually just talked. I mean, we do think, and, the governor on his 2 o'clock briefing again talked about still really having PPE be short in Ohio and having to reuse it. I 100% hear you that as a home healthcare worker, you are absolutely at risk of exposing yourself and exposing other patients. And it's really, really hard. I absolutely would tell you that you should be wearing a regular surgical mask and hand washing 100 times a day. I mean, my hands are raw at this point from hand washing as well. And there really isn't much else I can tell you. I mean, elderly patients that need care, and we have to do the best that we can do through this epidemic to care for them. I can't really speak to the legal issues at all related to that. I think in New York there's been some really rumblings about that right now because too, what do you do with doctors who specifically don't want to take the risk, or other healthcare workers where, in New York City, there was one hospital that had 13 deaths in the last 24 hours, right? They are rampant with COVID. And I think everyone is very fearful, but I don't really know what the legal guidance is there. Okay, my husband tested positive for COVID-19. We've been isolated since we got back from our trip to Spain. It's been 15 days now. He started showing symptoms on March 14th, so we've been told to stay home for 14 days.
Right.
After the first day started showing symptoms, how can we be sure he's not contagious to people after that period? Also, I've been with him the whole time and don't have symptoms at all. What should I do? So that's a really important discussion here, right? So the good news, first of all, for you is if you have not gotten sick yet, and you're at 14 days and you've been in close contact with him, you are probably out of the window of going to get sick. It's not impossible, but you're probably okay. You're probably one of those people that has an underlying reason that you're going to have an asymptomatic infection instead of a symptomatic infection, and we don't really understand that yet. That's the hope. Now, in terms of him, so from the day he started showing symptoms, remember, COVID is a really long infection. That's one of the problems with it, right? So people, when they get hospitalized, they're hospitalized for 20 plus days, right? They can be on ventilators for long periods of time. And what from the data, an article that I read coming out of China, looking at that was actually very concerning in that viral shedding was really happening for up to 3 weeks. Now, when I say that, viral particulate shedding, what's not really known is if at the end of that period of time when they were seeing viral shedding still, whether or not that people were still infectious at that point. For you, with very specific recommendations, since we know that he's positive, he's been sick, if you have the ability to get to 3 weeks before he had a lot of contact with anyone, I think at 3 weeks you can presume he's not infectious anymore. That gives you another week to see whether or not you're going to develop any symptoms at all. Again, we don't know for sure that you haven't had a mild infection, that you no symptoms, and you are also having viral shedding. So again, if you can push that to 3 weeks, that would be my recommendation for you. I don't think you need to get testing because you don't have symptoms. But I think one of the interesting things will be is when there is available to do serology, so we could actually measure whether or not you have antibodies, if that's available where you live, that might be something that you would want to do in the future. You would know that you did have an asymptomatic infection, and that for future outbreaks, you're really not at risk.
And that is many months down the road before we have availability, but I think that will be something we rely on in the future. But I'll emphasize, you're asymptomatic, you do not need to be tested. There is zero reason right now for you as an individual to be tested.
Would the fever aspect be the determining factor between long-term coughing for allergies and the virus symptom? So this is really hard. Yeah, you want people who have seasonal allergies, and obviously it's spring, and fortunately everything is really blooming now. Have a cough that's allergy reactive airway related, and how do you know if that's COVID or not? So fever is not 100% of the time, but it is really a predominant symptom. And so that's a pretty good, helpful, not perfect, nothing's perfect here, marker for it being an infectious etiology. The other thing really is other systemic symptoms, right? So with allergies, typically in a reactive airway cough, you really don't have systemic symptoms. With this infection, we know that people have a lot of flu-like symptoms. There's a percentage of people that have gastrointestinal symptoms with it, in addition to the fever. And then yesterday I talked about the loss of smell and taste, which we think is up to about 30% of people with the infection. So again, it's not 100%. This is why social distancing continues to be so important. If there's any question that you think that your cough is not just allergies and that it might be infection, again, I would really encourage you to do as much as you can to self-quarantine and social distance from as many people as you can.
And for sure, if you have any of those symptoms and you have to be going out or have to be going somewhere, or if you're a healthcare, if you were one of my healthcare providers and you were sick, I'd say stay home. After a period of diminution of symptoms, I'd still make you wear a mask for 7 to 14 days in the care area. regardless.
Can you visit friends if you are outside? So you go ahead. We had that conversation last night.
We sure have. Well, 6 feet is 6 feet. Outside is better than inside. A lot of people are taking walks together and doing it from a distance. Dogs are really happy right now, which is just terrific, and as it should be. Stay apart, but sure, absolutely, but stay apart. And it's not time to stand and linger and talk close to each other. But if you're 6 feet apart or more and you're out taking a nice walk, I think you should.
Right, and I think because Art and I both think that this is not going to be over in 12 days and that it's going to be longer than that. We could predict, but we'd be wrong. But still, I think, trying to figure out ways where we can have a little more social interaction and feel a little bit more normal is really helpful. And so I think from our standpoint as personally, as the weather's getting nicer, I mean, that is something we've been talking about with some of our friends, is whether or not we really can go on a walk and keep a little bit of distance, but at least talk and see each other and, get outside. So that's what I would recommend.
For sure.
Any other questions?
That we haven't addressed?
No, I think she typed them in there. Yeah. All right. Well, thank you very much. Sorry for the technology issues. I have no idea what that has been today. Actually, let me just make sure no one else texted me any other questions. Again, if we can be helpful in the practice, please call. We are available. We are actually the last week we've gotten our system down pretty well. So we're doing great with telemedicine and we're doing great with urgent visits in the office. So again, please call us if you need anything. And thanks, and I'll touch base with everybody tomorrow.